are going to begin with a presentation from Dr. Amma Rahimullah, who is Clinical Associate Professor at Stanford University in the Psychiatry and Behavioral Sciences Department. He specializes in the treatment of addiction and is the director of the Addiction Medicine Consult Service at Stanford Hospital. Dr. Rahimullah, the microphone is yours. We are anxious to hear your presentation.
Okay, great. Thanks so much for having me. Before we talk about inductions in the inpatient setting, I wanted to talk about the goals of induction, regardless of the setting. The induction is not the goal in itself, but it's a means to stable buprenorphine maintenance. And through buprenorphine maintenance, not using it once or twice, through buprenorphine maintenance, we get all the great outcomes like decreased mortality, improved outcomes, improved patient retention, decreased illicit drug use. The second goal of induction is to minimize withdrawal, to increase our chances to get to buprenorphine maintenance. So on one end, we don't want to give buprenorphine too soon and precipitate withdrawal. But on the other end, we don't want to wait so long that we unnecessarily prolong withdrawal. Withdrawal increases dropout. And if we can avoid withdrawal altogether, that's great. The third goal is keeping people on buprenorphine and illicit opioids is not the goal in people with opioid use disorder. The ideal goal is buprenorphine maintenance without illicit opioid use. The goal is to increase the buprenorphine as quickly as possible to achieve an adequate dose that treats withdrawal and cravings and to stop illicit opioids as soon as possible if they're continued. So understanding these goals of induction, then we have a menu of buprenorphine inductions available in order to achieve those goals. There's a great paper reference at the bottom that discusses macrodose inductions, microdose inductions, standard inductions. It summarizes the evidence, clinical scenarios that highlight which method to use, especially in the era of fentanyl. Feel free to read it. I'm going to attempt to give us a helicopter view of these. The first induction style, standard induction. So guidelines suggest clinicians typically wait for opioid withdrawal to manifest, then administer an initial buprenorphine dose of 2 to 4 milligrams, wait 1 to 2 hours. If well tolerated, administer additional doses in a stepwise fashion up to 60 milligrams on day 1. Some guidelines recommend up to 8 milligrams on day 1. High dose inductions differ in that they typically start with 8 milligrams or more. For example, the American College of Emergency Physicians suggests starting at 8 milligrams. There's also rapid high dose or macrodose inductions that start at 16 milligrams or more, as seen in the reference at the bottom, and you can administer up to 32 milligrams of sublingual buprenorphine within the first few hours. Low dose inductions are different in that they don't wait for withdrawal to develop. And in fact, if withdrawal develops, it sort of defeats the purpose of it. So with low dose inductions, we start with small doses of buprenorphine, small enough that they don't precipitate withdrawal, and these overlap their current opioid use. So, we're going to go into low dose inductions in more depth, but the point I want to make here is that you want to pick the best option for the setting and the patient. So when we talk about inductions in the inpatient setting on the next slide, the ED will be the emergency department will be the most often be the first point of contact prior to patients being admitted to the hospital. The ED will have its own set of considerations. Higher dose inductions are used here for many reasons, including the increased potency of illicit opioids, commonly encountered delays in access to follow-up care, and other reasons as well. It's important to recognize the ED is a low barrier setting to get people on buprenorphine easy and fast. If I want to go to the clinic to get buprenorphine, you have to schedule appointments, wait for them, so on and so forth. But the ED is a low barrier setting to get buprenorphine easy and fast. It also needs to be simple and fast for ED providers to get trained on and implement buprenorphine inductions. Complicated, slow protocols for ED physicians are not high yield and may not be practical for wide adoption. Most ED clinicians should continue buprenorphine inductions using established guidelines. such as those disseminated by the American College of Emergency Physicians, which recommend 8 milligrams, starting with 8 milligrams. This is likely going to be discussed more by our panelists, but the point I'd like to make here is that low dose inductions generally become a consideration when we're talking about the inpatient setting, generally become a consideration after patients are admitted. On the next slide, if buprenorphine is started in the emergency department, great. After they're admitted, you maintain that buprenorphine. If not started yet and their admission does not require opioids, then you have another opportunity to just start the buprenorphine directly while they're admitted if withdrawal is anticipated. However, if withdrawal is not anticipated, if their hospital admission requires opioids, like full agonist opioids such as morphine and oxycodone, which many hospital admissions do, then a standard induction or directly starting buprenorphine is not an option, because oftentimes patients will stay on opioids, full agonist opioids, throughout their hospitalization and perhaps afterwards, and we don't want to miss that opportunity to start buprenorphine in them. On the next slide, when people are admitted to the hospital, it's because they're ill enough to be admitted to the hospital. So regardless if people need opioids or not in the hospital, patients requiring hospitalization are often fragile and cannot risk opioid withdrawal, worsening their conditions. Opioid withdrawal is an unnecessary layer of complexity that affects multiple organ systems, and it can be avoided with low dose inductions. In one of the largest studies examining low dose initiation in the hospital setting, referenced at the bottom, researchers documented the reasons for using low dose buprenorphine. Most common reasons were acute pain, followed by patients already having a high level of distress while they're in the hospital, or medical fragility. Other reasons were previous failures with the traditional induction. Examples of patients that can't tolerate opioid withdrawal include patients with opioid use disorder who are post-op and require opioids for acute pain needs, or patients who have sustained a trauma, possibly due to being intoxicated, which fits the archetype of somebody with opioid use disorder. Also, patients with opioid use disorder and co-occurring acute psychiatric conditions. With patients with co-occurring acute psychiatric conditions, we have to treat their opioid use disorder to treat their psychiatric conditions. And they can't often tolerate the dysphoria and anxiety of going into opioid withdrawal before starting buprenorphine. Then there's people that just don't want to tolerate opioid withdrawal on the next bullet point. So there's people that are ambivalent about opioid use disorder medications, patients that are on methadone who want to switch to buprenorphine because of some new development in their hospitalization, which doesn't allow them to be on methadone, or patients in the outpatient setting, stable on methadone, want to switch to buprenorphine and don't want to go into the days of withdrawal that it requires to start buprenorphine, and also patients with a history of precipitated withdrawal. On the next slide, the point I want to make here briefly is that patients with opioid use disorder are increasingly being hospitalized. We can't afford to miss opportunities to start buprenorphine due to the hospital factors that I mentioned before. Many of these hospital factors are a downstream consequence of their opioid use disorder. As you see in the slide, opioid use disorder in hospitalized patients has quadrupled from 93 to 2016. The opioid epidemic has only gotten exponentially worse since that time. Also, opioid use disorder in hospitalized patients has been increasing 8% annually. So point being, low-dose buprenorphine inductions are an option for many patients in the hospital who would otherwise not be able to start medications for opioid use disorder. On the next slide, sometimes with low-dose buprenorphine inductions, there can be confusion about the names of them. The Bernese method was first described the low-dose initiation method, and the authors used the term microdose inductions or microdoses. The term microdoses is still used in the literature, but slowly falling out of favor because microdoses has come to be associated with psychedelics. The term low-dose inductions are being used more frequently. It sounds simpler, which reflects the simplicity of the principle behind the method. And the principle is that low doses of buprenorphine don't precipitate withdrawal. So the study reference at the bottom looked at opioid-dependent subjects who were receiving 30 to 40 milligrams of methadone. They were opioid-dependent. And they measured the vital signs and withdrawal scales in these patients and compared this with giving them placebo on another day. The point is, they found that low doses of buprenorphine did not cause withdrawal, and there was no significant differences from placebo. So what this means is precipitated withdrawal is not caused by buprenorphine. It's caused by the starting dose of buprenorphine. Withdrawal is not an inevitable consequence of buprenorphine's partial agonism and high binding affinity. It is due to the starting dose of buprenorphine. On the next slide, just to talk a little bit about how low-dose buprenorphine initiation works. Small doses, you start with small doses, which are considered 0.5 milligrams of sublingual buprenorphine or their buccal film equivalent, which is about 225 micrograms. Or you use 20 micrograms per hour transdermal patches or less. Those are considered small doses. The second main point, and perhaps the most important point, is to continue opioids to prevent withdrawal. Opioids need to be at an adequate dose to prevent withdrawal. So the transdermal protocol that we've been using for the last 6 years, we rarely see opioid withdrawal. And it only occurs when their full agonist opioid use is clearly too low to meet their opioid debt, their opioid need. So, and oftentimes, if you're unable to find an indication for opioids, then you can use methadone for opioid use disorder while you titrate up buprenorphine. And there's many protocols that have been used to switch from methadone to buprenorphine. Your third point is you want to titrate up the buprenorphine. Ideally, you are on an adequate dose of buprenorphine in a matter of days because hospitalizations can be unpredictable. There are several protocols that can get you on an 8 milligram dose of buprenorphine within 48 hours and 16 milligrams within 72 hours. If you know your patients will be there longer, then you can consider a longer up titration, but you want to avoid keeping your patients hospitalized unnecessarily if a faster protocol can be used safely. So the recent review at the bottom discusses different starting doses and durations that have been reported in the literature. So I'm going to attempt to simplify that. With transmucosal formulations, sublingual doses are commonly 0.5 milligram doses or below. The problem with that is the lowest commercially available sublingual dose is 2 milligrams. So patients have to cut their dose, or inpatient pharmacies have to cut their dose. So a half a milligram is a quarter film or tablet. And then and 0.25 milligrams, which is also used in the studies, is 1/8 of a tablet. And the duration to reach 12 milligrams in some of the reports have been by day 3, but typically these protocols, the sublingual protocols, are 4 to 7 days. The buccal formulation, the largest study using buccal film, started at 225 micrograms. The transdermal protocols start at 20 microgram patches or below, and 8 milligram doses can be reached by 48 to 72 hours. I'm going to start to talk about the barriers to transdermal inductions, and if we don't get to this or finish this in my time, what we can do is discuss the rest of it in our panel discussion. In general, transdermal protocols published tend to be faster, reaching an 8 milligram dose by day 2 and 60 milligram dose by day 3 or 4. Low dose inductions use patches. Using patches were first described in 2015. Patients were on 8 milligrams by day 2 or 3. This protocol was used at other institutions and shown to be safe and demonstrated the same timeline over the years. And another study that just came out a few months back, referenced at the bottom, shows that this faster transdermal option is still well tolerated with no incidence of precipitated withdrawal. And in their study, they had 54% of them as fentanyl users. The problem with the transdermal induction on the next slide, the problem is that patches are currently only FDA approved for pain, and they are expensive as an outpatient. So films are a few dollars, patches are a few $100s, and they're not consistently covered by insurances. And the transdermal route can be better facilitated with FDA approval for opioid use disorder, inexpensive transdermal formulations, or better insurance coverage. And on the next slide, I can talk a little bit about the barriers to sublingual buprenorphine. I believe I have a few minutes left. For the sublingual preparation, many of the protocols take longer to get on an 8 milligram dose, typically 4 to 7 days. But there are protocols that have been done in fewer days. For opioid use disorder patients, the goal is to reduce their time on illicit opioids or hospital administered opioids that are short acting and highly reinforcing as fast as possible. So shorter protocols are generally preferred, whether that be sublingual, transdermal, buccal. Also, the most common low doses are 0.5 milligrams to 0.25 milligrams on the next point. However, cutting the pills and films lacks precision and can generate uncertainty, confusion. They're difficult to explain, they're complicated to explain. High performance liquid chromatography analysis only showed a content uniformity in films cut in half. Inpatient pharmacies may not approve films cut in a quarter because of this lack of established content uniformity in films. But buccal film preparations are still available and still an option. And sublingual and buccal films are a great option, especially if patients are going to be hospitalized for days and will be around for that protocol. Some solutions to these barriers include manufacturing smaller doses of sublingual buprenorphine. If patients can just start on sublingual buprenorphine and continue on it, that's obviously preferred. Other solutions are pre-formulated medication packaging or blister packs to make dosing simpler, and more research to develop clinicians' confidence in sublingual buprenorphine's ability to do faster protocols. Thanks so much. We can skip this part. I know I don't have much time left. I can't do this justice. So
that's okay. Well, so we know we want to do this, and I'll ask our panel to come on camera while you finish that last slide.
Okay, great. Sounds good. So the evidence for low dose initiation is limited and based on retrospective studies, case series, and case reports. For opioid use disorder, we want to learn how to use low dose inductions to get people on therapeutic doses of buprenorphine of 8 to 16 milligrams or higher as fast as possible. So this means, what is the highest dose we can start with? How fast can we up titrate buprenorphine? And how fast can we get them off their other opioids? We also want to know what formulations and protocols lead to the most adherence. There are better quality studies underway. One randomized controlled trial is in progress with an anticipated completion date of 2026. Until then, we have enough information to start using low-dose inductions for people that would otherwise not start buprenorphine for opioid use disorder.
Excellent. So, Dr. Rahimullah, thank you I'm struck by your underscoring the different ways that individuals present and therefore the different, approaches that have to be considered. I want to invite our panelists to the conversation here. We are bringing 4 additional folks into the conversation, and so I'm so glad to see all of you joining us on the screen. So join